Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago. My name is Megan Phillip, and I am the Executive Director of HC3. We are a mission-driven platform proactively seeking uncommon alignment to improve Chicago's healthcare ecosystem. House, Senate, and Democrats have proposed expanding Medicare coverage to include dental, vision, and hearing benefits as part of the $3.5 trillion budget reconciliation bill. The move would be the biggest expansion of Medicare since Congress added a drug benefit in 2003 and will go a long way toward improving the health and well-being of millions of older adults. So today's conversation will explore the possible opportunities of expanding Medicare coverage should the proposal make it through the full legislative process. Before we dive in, I have two housekeeping announcements. This afternoon's discussion is being recorded and will be shared on our website, www.hc3.health, for later viewing and sharing. As we hear from today's experts, if you have any questions at all, please use the chat function, which will be seen directly by our moderator, who will do his very best to incorporate it into our conversation. So without further ado, it's my pleasure to introduce today's esteemed panelists: Jason Montrie, the president of Pareto Intelligence; Tricia Neuman, who's the senior vice president and director of programs on Medicare policy at the Kaiser Family Foundation; Dr. Chinni Pulluru, senior director and clinical transformation innovation operations at Walmart Health; and Marko Vujicic, chief economist and vice president at the American Dental Association. And today's moderator is our fearless co-founder of HC3 and the founder and CEO of Third Horizon Strategies, David Smith. Thank you.
Thanks, Megan, and thanks everybody for taking an hour out of your day to join us for the discussion. And also, of course, thank you to our four fabulous colleagues who have taken the time to share their rich insights with us. This is an exciting discussion. Medicare benefits oriented events can sometimes be a little dry and a little technical, but we're still getting to operate at the legislative level for this one. So there's a lot of dramatic politics going on, a lot of horse trading, and a lot of unknowns about what's going to happen with this particular provision. So just to tee up a little bit about this and to kind of set up the opposing sides, I'll just reinforce what Megan shared. For those of you who are watching all of the congressional drama play out between the soft infrastructure bill and this reconciliation bill, you know that there is a lot of horse trading right now. You know, you're hearing big numbers like $3.5 trillion, but Manchin and Kirsten Sinema are kind of proposing a lower number. So what stays, what goes, what are pay-fors? Plus, this all has to be done through the reconciliation process, which is just a really complex, parliamentarian-driven process that really can have a lot of changes at the last minute. Even after things are negotiated, things can still change, and you've got to kind of go back and renegotiate. So there's a lot of things in this reconciliation package, but one of the things that is probably most germane to all of our interest is this provision to expand coverage for Medicare, and to expand that coverage in a way that would allow for or require the coverage for dental, vision, and hearing benefits. And that's pretty seminal, because the last time we did a material expansion in the Medicare program was Part D, way back in 2003. And really in the 18 years since then, we haven't touched the program very much outside of some of the things we've seen out of CMMI and payment innovation or other programmatic changes. As you can imagine, this is a little bit controversial. And the two sides, I think, probably see this in kind of different ways. The benefits, and for those who are advocating for this expansion, look at this and they say, well, this is very natural. We have a lot of data now that tells us about the benefits of these ancillary benefits, how they complement a person's physical health. Why wouldn't we be covering these things? These ought to be savers over the course of time, particularly if they are reducing the potential burden or onset of more significant physical illness and disease. Those who are in opposition to the legislation they kind of point to two things. One, we kind of have a big solvency problem with the Medicare program as it is. And even if we're able to fund this, we still have a program heading rapidly towards insolvency. I think the latest year for that's 2024. Tricia might have more current information. And even if there are benefits to this, do we at least need to get our house in order on Medicare initially? I think the other kind of opposition might say, well, look, we've got this burgeoning market of Medicare Advantage. And Medicare Advantage has kind of started to figure out how to offer some of these benefits on a chassis, on a benefits chassis that really doesn't cost a member too much more money. So do we really need to do this, or can we kind of leave it to the private sector to figure out? So we're going to kind of suss through all of that today. We're going to start with our colleagues Marko and Tricia to talk just a little bit of the lay of the land, paint the landscape for us, and then we're going to get into some of the industry implications. As Megan said, if you have questions, comments, please feel free to put them in the chat. I'm watching it, and I'll make sure it's integrated appropriately. And with that, Tricia, or I'm so sorry, Marko, I'll tee you up first to share some thoughts.
Sure, thanks. Thanks, David and Megan, for having me. And Tricia and I kind of put together some kind of basic just the facts slides. I'll be brief, and then Tricia has some in-depth information, including on Medicare Advantage, David, what you said. So one of the things, again, I'm an economist, I study this market. One of the things we observe from various data sets is when we ask older Americans about what services they have affordability challenges on, or they face cost barriers on. We see one stylized fact is that dental care tends to be at the top of this list. And so, for example, in this chart here, if you go all the way to the right chart, we're looking over time here. This is NHIS data, but it's tracking the percent of seniors on the right who say they needed certain services but could not afford them. And you see the orange line up top is dental care, and then you have prescription drugs and eye care, and then you kind of go down the list there. Unfortunately, the survey doesn't ask about hearing. That would have been cool to include. But again, you see here cost barriers for dentistry on the right are higher than for other services, and have been slowly rising over time as well. That's what I wanted to highlight on this chart. The next one is a little bit of a comparison of where the US lies relative to a handful of other OECD countries, right? So the stylized fact here is seniors in the US tend to have higher cost barriers to dental care compared to other OECD countries. So again, this is a cross-section of a dozen or so OECD countries. This is out of the Commonwealth Fund. But again, stylized fact number 2 is seniors in the US, you know, even with what David was saying, kind of options in the private sector and Medicare Advantage, voluntary options, there still seems to be you know, an outlier effect here in terms of older Americans in the US have a tougher time paying for dental care than older citizens in different countries. Before turning over to Tricia, just one last thing is we didn't present data here. Tricia will have some looking at by race and by income, but just to kind of summarize the punchline in that type of research and analysis, there is a huge difference between lower income seniors and higher income seniors in terms of the likelihood that they face cost barriers, with low income seniors being much more likely to say that. And that's true for a host of other healthcare services, including eyeglasses. So I think that's an important thing as well. And there are definitely differences by race as well, with non-white seniors, again, more likely to report cost barriers than white seniors. We'll get into that, but Tricia, let me hand it over to you now to go a little bit more in depth.
Okay, thank you, Marko. And I'm going to show you just a few more slides. Really, we're trying to set the table here for our discussion. This is a little bit old, but the major point here is that half of all people on Medicare, at least a couple of years ago, had no dental coverage. of the 47%. There are those, the other half do have some coverage, but I think what the point I want to leave you with here is even those who have coverage often have limits on their coverage, which means they may not have sort of the full protection that would make dental coverage relatively affordable. What we have seen is that, for example, with Medicare Advantage, which now provides dental coverage to a larger segment, the coverage is very good for preventive services, but has high cost sharing for other more expensive services and is typically capped, which means that people who can afford their coinsurance and spending above the cap have significant dental needs, have high dental costs, but still many people who can't afford the coinsurance go without the dental care they may need. Can I have the next slide, please? Lack of affordable and accessible dental coverage is an issue, and as Marko said, it is an equity issue. What I'm not showing you here is that overall 47% of people on Medicare did not visit the dentist in the past year from a recent survey. Okay, that is a lot, but among Black Medicare beneficiaries, 68% did not visit the dentist in a recent year, and 61% of Hispanic people on Medicare. So when we talk about this issue, it is an issue that affects a large swath of the Medicare population, but particularly people from communities of color. In this slide, you see something different. You see out-of-pocket spending, because I get a lot of calls from reporters who say, well, which benefit is more important? And I hate those questions because it's like choosing your favorite child. But what you see here is what people are spending their money on. And you see who's using a lot of services. So dental services are used by a lot of people on Medicare, more than hearing or vision. But actually out-of-pocket spending is a bit higher for hearing services because hearing aids are so expensive, followed by dental. And then vision, about a third of all people report vision expenditures and vision services, but that's a relatively low expense. So my takeaway here is dental is relatively expensive, needed by a lot of people. Hearing also very important, needed by fewer people, but costs are also quite high. If you look at the next slide, thank you. What you can see, this is Medicare Advantage. So what we have talked about, what Marko mentioned earlier is that Medicare Advantage plans cover a lot of extra benefits, and we're going to talk more about that. And in particular, if you look at the orange bars, you can see more than 90% of Medicare Advantage plans are offering dental, hearing, and eye exams, and also some other benefits like telehealth and fitness. This is really great, and it helps to fill the gaps. That is the good news. I think the good news comes with some good questions that we're not able to answer, such as how many people enrolled in plans are availing themselves to these benefits. What is the nature of their coverage? We know a little bit more about that. We know that the typical plan has a out-of-pocket cap of, sorry, not an out-of-pocket cap, a maximum plan benefit of $1,300. That preventive services are often free, and coinsurance can be relatively high for other services. But we don't know how people are using these benefits, and I think that would be very helpful information to have, whether there are differences in use by race, ethnicity, and we don't know much about dental networks, and I think that's super important to find out whether dentists are involved in the networks of plans, whether they tend to be in some communities but not others, to see whether that contributes to access problems. The next slide is also a little bit surprising. We found it surprising. So this looks at out-of-pocket spending for people in Medicare Advantage and traditional Medicare. And what you can see is what we would expect, which is out-of-pocket spending is lower for people in Medicare Advantage than traditional Medicare, and we would expect that because more people have coverage. But we were surprised to see that the difference isn't greater. because we would have thought that the difference would have been much greater. So that is something that is worth taking a look at, I think, moving forward. And then the next slide, and I am going fast because I want to hear what all my fellow panelists have to say, is we looked at people who said they couldn't get dental, vision, and hearing for various reasons. And what we found here is there wasn't much of a difference between traditional Medicare and Medicare Advantage, which is what that blue bar should say. But there was more of an issue by race ethnicity, with more of a problem among Black and Hispanic than white beneficiaries, by income, and people in poor health. Which means to us that this is a health equity issue, that this is an issue for lower income people. They have lower out-of-pocket spending, but that's simply because they can't afford to incur the costs associated with dental care. And for some reason, people with poor health are having trouble getting to the dentist as well, which is also something worth looking at. The next slide, please. Thank you. So I have the unenviable task of trying to tell you what is going on right now in Washington. And I'm starting with the benefits that were passed by the House in HR3. And I just want to say from the outset that this is no doubt a work in progress, that the negotiations are ongoing. They are in flux. There's a lot of discussion about how much this whole thing should cost. The last time CBO provided an estimate, it was $358 billion for dental, vision, and hearing over 10 years. We haven't seen estimates for the current version. The notion is that there would be a new Part B benefit under Medicare that essentially means everybody would have this benefit. There would be co-insurance for preventive and other services. And there would be staged implementation dates. I think that's largely because it's going to take CMS a while to implement a dental benefit. You've heard this is controversial. I think we may talk about the views of the dentists who have not opposed a dental benefit, but have been supporting an income-related approach that would be tailored to people with lower incomes, that would be voluntary, so not integrated into Part B as other Medicare benefits are today. Whether that has legs on Capitol Hill, I can't say. I have also heard there's a lot of urgency to provide dental sooner than 2028. There's been talk about debit cards or vouchers that would be for dental, hearing, or vision. In some ways that adds to the cost, so I don't know where that's going to go. There are people who are simply concerned about the cost of this. I will say that these are through Part B of Medicare, which is paid for out of general revenues and premiums, not out of the trust fund that is projected to be insolvent in 2026. So Medicare does face financing challenges and solvency issues. These benefits wouldn't contribute directly to the insolvency of the Medicare trust fund, which will be a pressing concern in the next couple of years, though it does contribute to overall spending. So I think with that, I will pass it over to my very able panelists.
Well, thank you. I actually just want to I want to ask each of you one quick follow-up question before we pivot to our industry friends. And Marko, let me just throw one in your direction. Sorry, this wasn't on our question list, but I know you can handle it. So Marko, one of the things I know you guys have really thought a lot about over the years is the connection between oral health and physical health. And I'm just kind of curious, like what has your research kind of indicated? Like hypothetically, if we were going to make this a benefit and dental services, as our primary example, became much more accessible, could we expect or anticipate some positive implication health outcomes or lowering of cost for other Medicare benefits, or is it just too hard to extrapolate that?
I mean, the research in that area isn't perfect, and obviously, we don't have amazing RCT trials. But look, as an economist and health service researcher, it passes the sniff test in some areas, right? Like, for example, diabetics. right? So we know that people with diabetes who have uncontrolled inflammation or gum disease, right, have higher healthcare costs on average than diabetics who have their oral disease managed better, right? I'm being really strict. If you go to other kind of next level of research down, there's all sorts of connections with people with Alzheimer's, with people with heart disease. And I know Chinni will talk about that, how Walmart is integrating these services. So the short answer is, David, yes, there are likely to be what economists would call fiscal offsets in terms of healthcare cost reductions. There's debate about the size of those. For example, it won't pay for itself. The dental care won't be paid for entirely by the offsets at all. It's nothing like that. And also, I'm pretty sure CBO doesn't take that into consideration in scoring the bill, right? But to your point, there is growing research. There, to me, is enough research demonstrating the value of improved oral health on other outcomes outside the mouth.
Marko, thank you. And Tricia, Marko may have answered my other question for me, but I'd love for you just to opine for a second. And I should know whether or not the Congressional Budget Office has scored these provisions in the legislation. I don't. So question one is, have they scored it? Question two, you hit a little bit on the Medicare Trust Fund insolvency, and Marko just talked about some of the offsets. Like, is there anything that the CBO could end up doing that makes the fiscal path to this benefits expansion more palatable, easier, better for the program generally?
So CBO has not scored the current version, but to give CBO some credit here, like the current version's changing probably every day, and they're probably giving feedback to congressional staff. CBO is tough when it comes to these offsets. So I'm not sure, unless somebody came forward with very compelling evidence that dental coverage reduced hospitalizations, for example, that would be great for the trust fund projections, but the evidence would have to be pretty ironclad for that. And my guess is CBO is not going to be leaning in that direction, but I don't know for sure.
Yeah, well, that's interesting. It's a good segue, I think, Jason Montrie, to you. You run a business that is really grounded on these supplemental benefits for Medicare Advantage beneficiaries. So I'd love to get your take on the legislation overall, and the good and the bad that you might see with it as you think about MA. Jason, I'd also be interested, and I can remind you this question in a minute, I'd also be interested in the last thing Tricia just said. I know you guys have a lot of claims data, so have you run those kinds of analyses and looked at a cohort that has the dental benefit versus the one that doesn't, and been able to isolate any of those physical health costs that might be a step closer to the ironclad kind of thing? So Jason, have fun with all that. The floor is yours.
So thanks, David. And sadly, I think I also have a slide with graphs, but maybe before we dive into that, there's three perspectives that may be useful. One, Pareto, which is the data analytics business. We spend a lot of our time thinking about and working with the Medicare Advantage organization specifically about some of the questions that you mentioned, some of the topics that Tricia, I think, even brought up, which is kind of what is the interplay between some of these benefits and someone's overall health, and what are we seeing in the space. Our parent organization, Convey, which I lead the supplemental benefits organization on, we're the largest over-the-counter benefit provider for the Medicare Advantage world. And what we're seeing, in the supplemental benefits category, of which, dental, hearing, and vision are kind of key components of, is really an explosion of investment, not only in those benefits, but other benefits by the plans. We talked a little bit about that, I think, in Tricia's slide, but it's really exciting to see specifically for specific cohorts of disease states or socioeconomic groups that there's some significant investments that the plans are starting to put forward in things that we haven't ever, considered before. And so that's, I think, interesting. And then the third lens that I could offer to the questions really, David, is, what's that? When legislation occurs, what are the intended and unintended consequences? And in my previous life, as David knows, I was a part of an organization that built from the ground up an insurance company that came from a big piece of government legislation, and there was a huge opportunity there, but it actually I would say spectacularly failed because some of the unintended consequences. And so I think it's important, you kind of phrased it with opposing sides. And, I think about this not necessarily in a for and against, but, what happens if some of these things happen? And if this becomes a piece of legislation, what are some of the downstream impacts that we may see? So this slide, I think hits on some of the things you heard from Tricia say, which is something probably everybody in this call knows. There's a huge investment that the private organizations, the Medicare Advantage companies, have been making in dental and vision and hearing and over-the-counter programs really over the last few years. We're almost, they're almost table stakes to those type of plans. But one of the more exciting things that we've seen are these newer programs, and it almost feels like every day we're reading about whether it's social isolation, whether it's transportation, whether it's food and grocery, and really how do we better serve the whole person? Because what we do know is that the connection between all of those things and someone's health is real. So Marko kind of hinted at some, disease state with dental and what we think the connection between dental and someone's health is. We've spent a lot of our time, David, looking at that interplay between clinical information, the over-the-counter program specifically, and then other third-party data sets. And we have found that it's absolutely empirical that the folks who need and interact with these programs are the higher acuity members. These are the folks that the health plan is trying to engage with. These are the folks that are having a hard time, effectively accessing the system. And so, one of the things that we've been really encouraged about is to finally see investment in programs that 5 years ago no one would have thought ever could have surfaced in a Medicare program. When you think of air conditioning and pest control and food and grocery, and certainly as we think about unintended consequences, these pay-fors, right? And you think about where these benefits, if they're not included in the benchmark, what could suffer from that? And we've heard some pretty sobering statistics that we could be looking at between $700 and $1,000 a year in lost supplemental benefit dollars that plans would be able to kind of send to their members. And what you can see there is the types of programs that were finally emerging for individuals to better, kind of connect their health may end up being just the kind of programs that suffer because of this. So I think it's really important to understand what we're trying to do with this legislation, and that I think it's obvious that, dental, hearing, and vision benefits have a huge impact, not just on member satisfaction, but on overall health, as do a lot of these other programs. And the question really is, how can we as an industry, kind of better serve our members, both in the private marketplace and obviously in traditional Medicare as well, because these are all good for folks. It's how do we pay for it? How do we make it work? And, kind of less in the for and against, and more, how do we make it so that we can better care for the folks who need these programs?
Jason, let me just ask one quick question before jumping to Chinni, and that's, you may have kind of indirectly answered this, but what's the general disposition of the MA plans you guys work with about the proposed legislation? Because obviously, historically, this has been an area where MA plans can be competitive. They can add an additional benefit, and that makes their offering more compelling and attractive to seniors who participate in MA. The change of the benefit will obviously change the architecture of how those plans do that, as you were saying a moment ago. So is there support? Is there resistance? Are the MA plans kind of speaking with any unified voice for or against this on the Hill? Tricia, you may know part of that too.
Yeah, I would say one of the things that we're hearing, from we work with, the vast majority of the Medicare organizations out there in some capacity, is there's a real understanding of why that these benefits are important to the program, and there's a real desire to integrate these more across. I think the concern obviously is really around, will these benefits be included in the benchmark? Will they be able to be something that there's funding for? Obviously, you hear and can read about different ways that the folks drafting legislation think they should be paid for. But typically in both in health insurance and any industry, any additional cost doesn't always just come from either the largesse or the profit margins that the actors have. It's really, that ends up finding its way into the cost of the product or somewhere else. And so I think it's a real desire to be mindful that these are important benefits, but also understanding kind of the funding. And I think there's still work that's being done and discussed on will or will they not be included in the benchmark rates, and how will the rebates be handled, and kind of how does that interplay? And so I think there's a general acknowledgement that these are critical benefits to the members' health, and they've become what I think was introduced, many years ago as a sales and marketing type benefit. It's clear now that these are clinical programs that are integral to people's health.
And Tricia, any just comments on the mechanics of how Congress is thinking about that MA interplay and finding ways to strengthen what's happening versus kind of a wholesale change?
Yeah, this is a tough one for Congress, and I think Jason was alluding to that, because on the one hand, people in Medicare Advantage are already getting these benefits, and when Congress adds benefits for traditional Medicare, it increases spending on Medicare Advantage plans, and so that contributes to trust fund issues, because they're paid in part out of the trust fund. Like, that's just the way that goes. But the industry is very concerned about any kind of adjustment that would affect their payments. And so, I hear, when I talk to people on the Hill, I hear that the industry has been very effective in making the case that these benefits are very important, and the benchmark should be adjusted. But the flip side of that is that does increase Medicare spending for people who already have these benefits at a time when there are solvency issues that need to be addressed. But my own sense is they're not being addressed now.
Yeah, and then the inability to have what you called the ironclad evidence that might allow CBO to score pay-fors or offsets really does add to the budgetary cost, which just becomes a non-starter in the reconciliation process. All right,
yeah, can I just jump in? I'm sorry,
yeah,
just
go ahead.
Jump in right there, because I really feel like that is something that the Medicare Advantage companies could help with, because they have the experience, they've got the claims data. And if we could learn from that, I think it would be remarkable and helpful and contribute to these discussions.
Yeah, I agree completely. And Jason, you indicated you guys have done some research, and I don't know how much you've pulled out of that or how concrete it is, or you can make it. But if there was ever a time to take a data driven approach to really demonstrate what those pay-fors could or might be, this would be it. And I think individual MA plans will probably be a little loath to do that, but if you can kind of take that across a cross section of MA plans, there could be some real value. All right, Chinni, saved you for last because I love what Walmart Health is doing. I'm just going to brag on you for a second, but I'm going to try to not steal too much of your thunder. Some of you may be aware that Walmart has really been experimenting with this model of building clinics adjacent to their stores. We have two in Chicago. One is in Austin, the other is in Chatham. I had the opportunity to tour one of these, must have been 4 or 5 months ago. But they have dental services in there, and I'm gonna let Chinni tell you more about all of that and their take. But it was one of the coolest things I've seen in healthcare in a long time. Very modern setup, dentist practitioners on site, a rate chart that goes into every dental things that I didn't even know existed and hope I never know exist. And just very accessible and very available. So Chinni, I would love for you just to tell a little bit more about what you're doing, the kind of take up you're seeing in the community. This equity challenge that Tricia pointed out is obviously something you guys are thinking a lot about at Walmart Health. And then how are you guys seeing this legislation? And what do you think the positive or negative implications are for the kind of work you do?
Thanks, David. So to start out with, I thank everyone on the panel. I think this is great dialogue and much needed. We at Walmart feel pretty strongly that access to affordable care and expansion of care into things that are needed is important, and strongly support that. Now, there's a lot of details underneath it as far as the economics of how that plays out. And I think, there needs to be more work done on how that ends up being legislated. But we are, in principle, very strongly supportive of that type of expansion to access. So if you think about what we've done, I mean, we've really centered on Walmart Health has primary care with behavioral health as well, embedded in the primary care module, nurse practitioners, a physician. It has dentists and one-stop dentistry. So it's procedural dentistry as well as we print our crowns on site and are able to do that when a patient comes in. The price point and most of the prices we offer, cash price point, we bill insurances as well, is about 75 to 80% less than average industry price points. And really that is to provide access. We do have free hearing tests, and our hearing aids are also sold at a pretty steep discount. So for anybody who wants a free hearing test, are able to come in and get one. We also have optometrists that staff our clinics, can do eye exams. And so and as you know, the vision centers that we have in about 3,000 Walmarts are the price point of the glasses are very reasonable on a daily basis. And so, our mission has always been to increase access to healthcare. We did that with $4 generics. We're doing that now with $0 copays on our Walmart Plus. And so that's only translated to what we've tried to do with the Walmart Health and as far as access. The reason we decided to do this integrated model is exactly the study. This is when I see these statistics come out that are being debated now, right? As far as the need that people have, we have mirrored our sites from when we started and exactly those service lines because we saw the need. And out of 5,000 Walmarts, 4,000 of them exist in HRSA medically underserved areas. So those are areas that there are medical deserts, there is not access to care. And one of the things that we found is just incredible demand for dental care. We're seeing people, a lot of our sites, almost half of our visits are dental care. And so we're seeing people just come in seeking this care because they just don't have the access. And when we ask them about access, it really does come down to the barrier being the price point, to be honest with you. And so, you think in the statistics that everyone showed earlier, that's a lot for seniors to pay. These are folks that are living paycheck to paycheck. They're people who are rationing medications, and to think of paying $1,000 almost for dental care is significant. The average hearing aids cost $4,800. So you think about that, right? And if you think about 1 in 5 Americans are diagnosed with hearing issues that need a hearing aid. And so untreated hearing loss in these older adults can lead to both physical issues, they can lead to mental health issues, so higher risk for dementia, higher risk of falls and depression. So one thing I would add is if we were going to go back and look at the analytics, right, and you looked at people who are diagnosed with hearing loss, maybe untreated hearing loss because they couldn't afford a hearing aid, you could always pull the CPT code on that and then look at, did they have a fall? Or did they have any of these other things that could contribute to, do they have depression? Do they have higher rates of dementia? And then you think about social isolation, I had a grandfather who I went to visit once in India a few years ago, and his words were slurring, so people couldn't understand him. And he was kept in, and what triggered my thought was he kept turning the TV up. And it was at a point where I couldn't talk to him. And I finally just looked at everybody and I said, has he had a hearing test? He's 80 years old. And all my uncles said, no, he refuses to get a hearing test. Well, I took him in for a hearing test. And then he refused to wear a hearing aid. And I can tell you after, in that trip, I managed to convince him to wear a hearing aid. His words aren't slurred. He's engaged in conversation with people now, whereas before he would turn the TV up to drown out everyone else because he could see their lips moving, but he couldn't hear them. And so you think about from the viewpoint of taking care of frail seniors, what that does, right? And so these are significant things. People who have vision loss, a 2016 report from the National Academies found that about 1 million people in the US have undiagnosed or uncorrected vision deficiencies. And early treatment of eye diseases, we know prevents blindness, right? And so, we're proud that we are able to offer that in, 3,200 stores everywhere. We stayed open during the pandemic. This was a big deal to us. And so you know, we support this access, we support the expansion. It really, but we also recognize that the devil's in the details, and there's economics to be worked out. And I think that, you know, that's what we all need to aim for.
Chinni, I know you guys are still on the earlier stage of your Walmart health aspirations, and still really trying to identify the high impact areas and markets and what works, what doesn't work. Do you have enough data at this point that's kind of getting to that question we were all playing with a minute ago, in terms of somebody that can't access dental, vision, or hearing benefits versus those that can and do through Walmart Health, and what the distinction of cost is? Like, is your data able to tell you anything yet, or is it still a little too early?
Yeah, it's too early, David, and we're just beginning to enter the value-based care space and the ability to take on risk. But if you look at, I'd love to have a set of claims data to play with, because if you think about that, hearing loss is associated with higher healthcare spending. And if you look at, there was one study, and I forget exactly where, but it showed that those reporting hearing loss in the past year were 49% more likely to not have a usual source of care. So they went to the ER, urgent care, instead of a primary care doctor or other regular sources of care. And so if you think about issues such as ER decompression, right? And people who have hearing loss or vision problems that have falls and then have to be treated for those falls. I would venture to say that if you actually set up the data correctly and looked, we would find that there would be decreased healthcare spending associated with treating these. Now, how much and whether it pays for what those benefits are, that's for people to decipher. But at the same, I would be hard pressed to think that elderly populations that have hearing loss or vision loss don't overutilize the emergency room, or don't have adverse effects that are causing higher medication spend, such as depression.
Chinni, just for the record, I happen to know a guy that has a lot of access to claims data. I'm just saying, he may or may not be on this call, may or may not be a panelist. I mean, I'm just throwing it out there.
We took a look, David, because we're really interested in this question, and one of the easiest places for us to start was the over-the-counter program, because that is a place that wasn't as saturated for MA as dental and vision and hearing. But I think a lot of the tenets that we're talking about are going to play true. And what we found was that it was absolute that that the individuals who were using that benefit were performing better in a like-to-like cohort. So diabetics who engaged with that over-the-counter program performed significantly better, less ER days, less overall spend, better cared for than individuals who are not interacting with that program. Falls, burns, there's very specific, condition profiles where that particular benefit had an outsized impact, some where it was less. And so, we know that when we as a system can engage members in benefits that are designed to care for them, that it works. And certainly, I'd expect if we had that data for dental and vision, that you would see, and hearing certainly, that you would see that, kind of play out. And I think one of the most eye-opening things we just did was took a look at a really large population that was underserved, and specifically looking at SDOH as a category. What we found is a third of this population, pretty big population, had a housing, food, transportation, or isolation identified issue and gap, right? And so we're just at the beginning as an industry of understanding all of those factors that go into someone's health, and designing and creating an ecosystem where companies can design programs to care for that. And so I think it's really exciting to see in that space. I know there's a lot of really innovative, cool things happening in dental and vision and hearing too. And I think the fear certainly that some of us have is that will any of that potentially get stifled or muted or rerouted as we think about whatever this legislation may or may not need for this kind of emerging category.
Yeah.
Go ahead, Chinni.
Well, one of the things that I think is often overlooked, right, is that there is a supply and demand. So if you go to underserved areas, such as urban areas, such as Chicago, our Chatham and Austin sites, people don't have access to dental care. They don't have access. It's not, your average dentist isn't setting up shop in those neighborhoods. So what drives people to provide access, right? It all comes down to the flow of money and the economics of how things are funded. And we all know this, right? And so, if all of a sudden dental care was paid for universally, I would venture to say that people would find a way to provide access to people who don't have them. And oftentimes things like being paid for telehealth made people do telehealth, and so there is what we often miss is that there is a supply and demand component that reduces health inequity. And so once you start to pay for things a certain way or for a certain population, people who live in areas that don't have access to healthcare, it incentivizes people to go set up shop in those locations because it is economically a feasible thing all of a sudden. I mean, it's not necessarily something that I think people are looking to, make an extraordinary amount of money in, but it just becomes something that is economically sustainable versus, losing money on it. And so these things drive each other. And we have to remember that there is a relation between them.
Yeah, Marko, I know you wanted to jump in, so I want you to make the comment you were going to make, but I want to tack on one question for you, which is on the supply side of this for dentists, generally, and then dentists maybe in some of these underserved communities, how are dentists thinking about this legislation? And if it passed, what would be the uptake rate? We know on the physical health side that Medicare pays less than commercial rates, and so sometimes that leads to caps or a lack of interest in serving Medicare patients. Will we see the supply side of this kind of come along with the legislation, or is that going to take time?
I mean, it depends, right? Depends on how the reimbursement structure is organized and how the kind of administrative burdens are. You're totally right. I mean, if it follows kind of the medical paradigm where it's, Medicare pays much more than Medicaid, for example, on average, but less than what private insurance plans pay. I mean, yeah, you're going to have a spectrum of dentists, but we did some research a few years ago showing that, yeah, there would be take up, right, with adequately funded. The whole thing here becomes whether the program is adequately funded and can pay well enough and be organized such that you recruit enough providers into the network, like Tricia was saying. But one thing with Chinni, my take on the research on the provider side is, again, the maybe we're saying the same thing, but the top barrier people report is I can't afford it. It's not I can't find a provider or it's too far to travel. Now, obviously, there are pockets of the country where that's true, right? So, I mean, it's in, your perspectives. Will this address kind of geographic shortages? I'm not sure, right? I'm not sure that's the issue, but again, it might. But I don't know. This is where, again, Tricia was alluding to the ADA's position on this, right? To focus the benefit on, 300% of the poverty level and below, which is about 40% of Medicare, 47% of Medicare beneficiaries. Exactly, David, for the reason that, look, if there's a fixed pot of money, and look, I don't know, I'm not in the politics of this, but it's looking like the price tag is going to be dropping. Is it better to kind of narrow those funds down on the most needy? Now, the program's not organized that way, right? So this would be a pretty big step. But anyway, that's where kind of the ADA came down on this, saying, yes, there are unmet needs. There are populations that definitely need coverage, but let's focus it on those that are kind of most vulnerable. I'll skip my other comment. It was just related to the research, but we don't need to talk about that. These are more important.
No, it's we may come back to that in just a second. I'm fascinated with the notion here because I think both things can be true at once, right? We can both have cost barriers, but we can also have access barriers and the inability of being able to find a dentist in a community. And I know, for a fact that, for example, on Chicago's south and west sides, there's no corner family dentist office. You'll see the banners or the signs of the dental practice that used to be there, but it's in a rundown building and a business that long ago left. There are limited options. Marko, I love the notion. Tricia, I want to pitch you a question, which is, okay, if we had to rationalize the rollout of this benefit, Is there an appetite to do this through means testing or becoming really data oriented and identifying those communities that have major access issues? I'm old enough to remember Part D's implementation, and I had to work for Mike Levitt for about a decade after he had left the Office of Health and Human Services, or the Department of Health and Human Services. And I know one of the challenges with Part D's implementation was it was such a big benefit expansion. It was really hard to get that right. So do you think that the lower price tag might help with a more strategic, tactical way of getting at this? Or if we're gonna get this done, we just gotta go big and figure it out as we go?
Yeah, I mean, a couple of things. Let me just, before I answer that, just say, remember, there was a lot of resistance to Medicare from doctors who were worried that Medicare wouldn't pay enough and they wouldn't be able to serve and all that. And, the vast majority of doctors take Medicare, their closed practices to people with private insurance and Medicare, but Medicare's been a pretty successful program in terms of physician access. So you could see that could happen for dentists too. In terms of scaling back the benefit, I actually think there would be strong resistance among Democrats to creating a means tested benefit under Medicare. I mean, there is progressive financing, there's income relating premiums so that wealthier people pay more. But the whole idea of Medicare is it's a social insurance program. So I don't know how that would fly, but I think there are other ways to scale back the benefit if that's what policymakers want to do. For example, the House bill basically buys down the premium so that people don't pay more in premiums to get this new Part B benefit. Well, that's expensive. That's something that maybe they'll say, well, we're willing to see premiums rise in order to cut the cost of the program. Or, there are other ways to scale back the benefit. I've heard some people say, let's just go with prevention. Let's do all the preventive services. I don't know that people would think about that. But I actually think what's really important is whatever is done is done well. And so you want to give the administration time to create it so that dentists are come on board. They know how to submit their electronic claims. People are educated so that it works. Because I think it'd be a disaster to create a new benefit and have a bunch of kinks in the system so it doesn't work. And that may take some time. It may not take till 2028, but it won't. I don't see it happening overnight.
Yeah, it's super helpful. And I want to recap a couple of things that have come in for the discussion. You guys have actually hit on some of these questions really well. I do want to point out something that Margaret O'Hara said. I'm going to read it verbatim. Access is a big problem. Look at what limited service Indigenous people have in the reservation areas they live. Preach, strong comment, and something that I think we ought to think a lot about. Hanish Bansali, sorry if I mispronounced it, talked a little bit about Oak Street's earlier experience. They had trouble to make the economics work. He made a couple other comments that I think you guys have hit on. Cassie Yarbrow, and Jason, I'm going to tee this question up for you, and I'm going to read it verbatim so I don't just totally botch it. It says, what are the panelists' thoughts on how including these benefits in Part B would affect the MA industry and also the private insurance industry overall? Could it upend what health insurance looks like or make the market more standard? I think it's a great question. Then any thoughts on how this might impact Medicaid? And Jason, you might not be thinking too much about Medicaid, but any thoughts on the first part of that question?
No, we think about all of the markets. There's so much intersection between the customers and all of the Medicaid and Medicare and how many dual populations exist too. It's hard for any plan to think about one without understanding the effect on the other. Some certainly focus more on one than the other, but our mind's always there. I think if we look at any precedent of a benefit design getting then implemented into kind of Medicare, and then what happened after that, I think would be something that would be worth looking at. So whether it was behavioral health and some of the things that have happened there, what happened to the industry, you know, kind of after that, how was that funded, financed, what can we learn from that? I think too often times as an industry, we act like this is the first time a concept has been, you know, explored, when there's plenty of lessons learned in even other places. If it's not Medicare, it's the Affordable Care Act. If it's not Affordable Care Act, and Medicaid. How do we strengthen a benefit? How do we pay for that benefit? And what are the aftershocks of that benefit to the system? There's so much that we can look at over the last, 15 to 20 years to pull out. Now, whether we have the political tolerance to admit things worked and didn't work would be a topic, David, that you're probably better at navigating. But I think there's plenty of lessons learned throughout government programs and the ability to enhance, strengthen, and pay for benefits. And so I know it sounds probably like a vague answer, but I think that you'd find the industry a much willing party if we could actually look at things to say, how did this work with other areas, and how do we take what worked well, make it not administratively burdensome. The industry tends to be pretty agile when I think there's Chinni and Tricia have talked about the economics makes sense. It's a pretty rational market in most places, right? And that tends to be what you find in healthcare is when the supply finds the demand, when the economics work. So
yeah.
Can I ask?
All right.
My take was, will it cause patients to go back to traditional, or beneficiaries to go back to traditional Medicare and out of MA? That was kind of what I thought. Is that not how the decision-making works? Okay.
I don't think so. I mean, having seen a ton of MA patients and, advised family members as well as patients on that conversion, people who get into MA are typically very happy. You almost rarely see someone go back to fee-for-service Medicare, because I think that they feel there's not just a host of benefits, but they feel better taken care of in some ways, because all of a sudden they have this 45-minute visit and they get called by their doctor all the time. And, there's definitely advantages that I think. So I don't see that going backwards as much.
Okay, panel, so I need your help. We have 4 minutes left of the program. Megan's gonna kill me. She's like stressing out in the background right now. So in 2 minutes or less, I want you all to answer the same question that I'm about to ask, which is, let's assume this legislation goes through as currently proposed, as we've been talking about. Fast forward 5 years, what's one good thing that's happened? What's one unintended or unexpected thing that's happened? Chinni, I wasn't going to put you on the spot first, but I'm going to give you a second to think. Anybody want to just jump in real fast? 30 seconds. All right, Chinni, you got me?
Yes,
Don't kill me.
Say more seniors get care and access care is good. There will be probably a lot of croppings of institutions, I won't say providers, institutions that might take advantage of this newly funded system. So
we are at a conference right now where I can see that being a thing. Yeah. Okay, Jason, quick.
Yeah, I think as an industry, hopefully we've recognized how integral these programs are to an overall person's whole health. And are continuing to design programs around that. I hope in unintended consequences that these other emerging, really important programs don't suffer from them. I hope it's not taking from one to fund another, because it is critical that we as an industry start to understand the importance of the whole person's health and invest in those categories. And I hope that what we don't see is one funds the other.
Tricia.
I am going to agree completely with what Chinni said. I'm not going to disagree with Jason, but I was just taken with what Chinni said. And I think where we're going to be back is because we're scaling back the benefit. I think, we're going to be back 5 years if they adopt the benefit, going like, wow, this stuff's still unaffordable. And we'll be asking some of the same questions like, people can't afford it. Is it reducing hospitalizations? What do we do? How is it improving health? What can we demonstrate? So I fear we'll be not too far away from where we are today, even if we've made some progress.
God, I hope you're wrong, but I think you're right. Unfortunately,
I hope I'm wrong too.
Yeah,
I'll start.
Mark, the last word.
Yeah, and then to piggyback off Tricia, I think one of my cautions is if we continue with the fee-for-service kind of payment model, that we will under-incentivize prevention and focus too much on fixing disease and downstream effects. I think we need payment model reform in conjunction with this. But let me end with the great thing, the optimistic thing. I think we'll start to break down the silos with these 3 services and the rest of primary care. Chinni's doing it on the ground, but I think we'll accelerate that, which is a really good thing.
Marko, I completely agree. And that is a fabulous way to end the discussion. So thank you thank you for the optimism. I want to thank the 4 of you. Super rich discussion. We could go another hour. We can't. So with that, thanks to those that tuned in. Megan, I will kick it back to you to play us out.
Thanks, everyone. I want to thank David and Chinni and Tricia and Jason, Marko for sharing your time and expertise. I know we're all busy, but thank you all for tuning in. As mentioned at the beginning of the session, this will be recorded and shared on our website, www.hc3.health, for later viewing and sharing. Our next event is next month, November 16th, with Weber Shandwick talking about health equity. We'll see you next time. Have a great day, everyone.
Thanks, everyone.
Bye-bye.